Hello, my name is Jennifer O'Connell. I am presenting my DNP project today, which is entitled A Process Evaluation, Fall Prevention at a Group Home for Intellectually Disabled Patients. My committee members include Dr. Sabrina Condon, my chairperson, my nurse 705, faculty member is Dr. Lisa Stewart, and Dr. Sandra Cobbler is my community member. Each member has been instrumental in the completion of this DNP project. In patients with intellectual disability, or ID, falls are a common contributor to injury or even death. Intellectual disability is defined by significant limitations in intellectual functioning and adaptive behavior, which affects daily social and practice skills that arise before the age of 18. Regarding hospitalizations related to falls, patients with ID have nearly equal hospitalization rates to the public. However, because most of the patients are in a group home type setting, it is essential to ensure proper care is received after a fall in their facility because they have fewer emergency room visits for patients who are status post-fall than the public. Evaluation of the current fall assessment protocols and prevention strategies within this group home setting will identify possible issues with adherence to the policies and allow for recommendations to improve current fall assessment protocols. This will assess barriers to following fall prevention procedures, as well as potential lack of knowledge of direct support staff regarding fall prevention techniques. As a nurse with 16 years of clinical experience, this DNP student has witnessed and cared for many patients after falls. From personal experience, most of these patients were geriatric, intellectually disabled, or both. Frequently, after a thorough review of the patient's fall assessment, management found errors in not only the evaluation of the patient, but also in the implementation of strategies to prevent falls, such as anti-slip socks, bed alarms, and wristbands that would alert the staff members to the patient's high risk of falling. One study showed that out of 854 ID patients, 39% had a history of a recent fall, while a survey of 350 patients revealed that an injury occurred at a rate of 0.33 to 0.68 per person year. These studies went on to show that ID patients residing in group home or residential type home settings fell more frequently and at a younger age than their non-intellectually disabled counterparts. This scholarly project aims to implement the Morris Fall Scale, or MFS, in the long-term group home care setting for IDD patients. The aim is to reduce falls during the 12-week period. The Director of Nursing will amend the policy to include the Morris Fall Scale on admission and after each fall in the facility if it is deemed effective during the trial time. The project seeks to answer the following. In ID patients residing in a long-term group home type setting, does implementation of the Morris Fall Scale as compared to current method of no standardized fall assessment tool reduce the number of falls over a 12-week period? Patients with IDD are at an increased risk of falls. There is a need to understand the efficacy of interventions that can help reduce falls and address risk factors in this specific population. 7 studies were reviewed with a total of 286 ID or IDD patients with a mean age of 50.4 years of age. Of these 7 studies, 5 evaluated exercise interventions, 1 calculated falls during a clinic program, and 1 evaluated stretch fabric splinting garments. Studies noted that although these studies reported a reduction in falls, they differed in methods of reporting falls. Statistical analysis was not used in most of these studies to evaluate the outcomes. This data only further proves the additional studies are needed to assess the fall risk of this population. Some studies report fall rates up to 47% for IDD patients suffering from a fall within the 12-month period, which is 50% higher than elderly patients during the same time frame. These patients are at risk of avoidable injuries such as fractures and acute brain injuries and at a higher risk of recurrent falls. Although several studies have focused on falls in this susceptible population, the findings vary due to differences in sampling and methods of documenting falls. There is a clear need for improved standardization to identify fall risk factors, implement interventions, and properly report falls. These patients suffer from cognitive, behavioral, sensory, and communication barriers that increase their risk of falling simply due to the disability. Therefore, based on the analysis of the literature, it is evident that the IDD population is at a high risk of falling and that additional research is necessary to implement the best practices in this subset. An integrated review of the literature was conducted on fall assessment tools for IDD patients in nursing facilities and yielded 10 articles for review. They were selected because they all shared the terms intellectually disabled and falls in the articles. The 10 articles were grouped into recurring themes for review. The most prevalent themes were risk factors, recommended screening tools, barriers, and interventions. The objective of this review was to find recommendations as the most appropriate fall assessment tool and be able to substantiate the need for the adoption of the Morris-Fall scale at the facility. Falls occur in facilities for a multitude of reasons across all populations of patients. However, fall rates are higher in IDD patients than in the public. A study comparing geriatric populations in nursing facilities with adult IDD patients in facilities revealed that IDD patients were at a higher risk of falling. The rates are higher due to the risk of comorbidities, lack of impulse control, and the use of ambulatory aids. Cognitive limitations play a crucial role in the overall risk of falling in these facilities. Although dementia is associated with elderly patients, intellectually disabled patients can suffer neurocognitive delays at an even earlier age. Thus, IDD patients in early adulthood may have the cognitive limitations seen in demented geriatric patients. The number is only expected to rise as the number of IDD patients reaching geriatric ages climb across the United States. Patients are living longer, which increases the young IDD patient's risk of falling as the geriatric years are reached and additional fall factors are faced. Physical ability must be considered with a patient's general health and comorbid condition. Seizure disorders and genetic brain anomalies predispose an IDD patient to falling. Fall precautions may be proactively put into place. However, a patient may suffer a medical emergency when ambulating, which leads to a fall. The Morris-Fall scale takes secondary medical conditions, fall history, and medications into mind during the assessment to alert staff at the increased risk of falling. Pettigrew and Whip described a process of enacting change via the dimensions of strategic change. To implement a change in a process, there are 3 distinct steps that are taken: content of change, process of change, and context of the change. In the first stage, the goals are pinpointed after a problem is identified. In this case, the fall rate at the facility is nearly double the national average. A research study revealed that at least half of nursing home patients had a fall each year. The problem is the fall rate, and the goal is to reduce the number of falls to avoid patient injury. The process of change is seeing it through the change. Management must monitor the speed at which the change is taking place. The Morris-Fall scale will be added to the admission packets at the facility and also used for a change in the patient's condition, such as a fall. This will initially occur over a 12-week period with the hope of implementing the tool into the computerized charting system once effectiveness is supported. Effectiveness will be based on the decrease in fall rate at the facility during the specified time. The context aspect of the model focuses on the internal and external forces that are at play during the implementation of the change. It may be the internal attitudes of the staff members who may not understand that simply being IDD marginally increases the likelihood of a fall. It may represent the internal fear of the patient who is afraid of falling yet unable to ask for assistance. External factors play a role in the risk of fall rates. The external factors is the fact that no standardized fall assessment tool is utilized at the facility. The environment itself plays a role as an external factor as it presents various possible hazards for the patient. This facility strives to make the environment as home-like as possible. However, this can present hazards that infringe upon the safety of the patients. Fall precautions are enacted at the whim of the nurse completing the initial admission. Management, an external factor, must come in and place the onus on the staff to properly assess the patients to avoid injury. The final step is the actual process itself. This is represented by the Morris-Fall scale. Every patient will have a Morris-Fall scale completed on admission and with any change in condition. The facility will be able to quickly identify those who are moderate to high risk of falling and implement proper precautions to avoid potential falls. This quality improvement initiative uses quantitative exploratory method to determine whether the interventions was effective and statistically significant. Prior to this quality improvement project, there was no standardized fall assessment tool used at the facility. To consistently implement the current practice guidelines and improve patient outcomes, a quality improvement program will be implemented at the facility in collaboration with the Director of Nursing and charge nurses. This pilot project will determine the effectiveness of the quality improvement program designed to reduce the fall rates in the IDD population and to meet the standards of care, provide appropriate interventions, and improve outcomes for this population. The sample will include the paper medical records of IDD patients at the facility who are 18 years of age or older. The focus of the study is IDD patients, as they were disproportionately faced with higher fall rates than the general public. The fall rate in the IDD population over a 12-week period was found to be 34%, which equates to a mean of 7.21 falls per patient. The sequential inclusion and exclusion process will continue until the anticipated 180, which is 90 pre and 90 post-intervention paper charts, are reviewed. The DNP, or Doctor of Nursing Practice, scholarly project will be conducted at a local IDD facility in the northeastern region of the United States. A vulnerable population comprised of adult IDD patients will be targeted for this project. Paper medical records from the clinic will be utilized for data collection. The minimum necessary data to accomplish the goal of this project on data collection sheet will be collected. All potential patient identifiers will be removed and not collected for this project. It is anticipated that 90 patient paper charts between the dates of October 1st, 2024 through December 17th of 2024 will be included in the inclusion criteria. The patient must be at least 18 years of age. 90 paper charts will be reviewed for pre and post interventions, during which time the Morris-Fall scale will be initiated and the duration of the standardized assessment tool. The importance of obtaining quality, trustworthy data is the backbone of a successful research project. In this study, the data was collected via a retrospective chart review of 90 patient paper charts. The number was used to provide an adequate patient sample size for the population at the facility. The patients were never actively engaged by the author, and patient identifiers were not collected to maintain HIPAA compliance. The paper charts were reviewed using an inclusion and exclusion process, which each record being assigned a numeric value to correspond with patient initials. Descriptive statistics were collected via various columns on the data collection form. The sample size in this study was adequate for accurate interpretation of the results. In the study, 90 patient charts were reviewed of the total 108 total patients residing at the facility. The charts of 18 patients were removed from data collection as the patients did not meet the age requirements for the inclusion criteria. Therefore, the population used in data collection accurately portrays the adult population at the facility. The data analysis plan for the scholarly project consists of various procedures to ensure that information is accurate and dependable. Data will be collected for analysis and dissemination. Statistical analysis will be conducted on the quantitative data that is collected. Quantitative research collects numerical data and allows for analysis that is expressed in numerical terms. Nominal data will be collected for statistical analysis in the quality improvement project. The nominal data will be in the form of yes or no answers related to whether the patient experienced a fall during the given time. Codes will be used during the data collection process, with 1 representing yes, 2 representing no, and 3 representing not applicable. This will utilize a pre-post design model to depict the time prior to the implementation of the Morris-Fall scale, as well as the time after implementation. The nominal values will include whether a fall assessment scale is completed on admission, readmission, after a fall, or change in condition. To analyze the data during the quality improvement project, 2 programs will be utilized: Microsoft Excel and Statistical Package for Social Sciences, or SPSS. Upon completion of the data collection, this information will be transcribed into Microsoft Excel. The more advanced statistical analysis will occur when the data is entered into SPSS. Microsoft Excel and SPSS were selected because they enable data to be extracted for statistical significance pertaining to the project. This data will produce a rate which refers to the total opportunity that a patient has to fall. The final product will consist of 2 fractions rather than a decimal to provide a more accurate representation of the data. The dependent variables are the yes or no values related to the fall. The independent variables refer to the pre-post analysis. The z-test will be used to note the difference between 2 proportions in the form of a chi-squared. Existing z-test for uncertainty does not provide information related to the indeterminacy of the test. Z-test measures the number of standard deviations that the pre and post data lie away from the mean. Therefore, the z-test will determine if the Morris-Fall scale decreases the rate of falls by comparing the difference in standard deviations. To test the null hypothesis that no difference exists between the use of no standardized fall assessment tool compared to the Morris fall scale. If no difference is noted between the pre- and post-intervention groups, then the null hypothesis can be rejected. It was determined that 154 patients' charts would be required to obtain the power of 0.80. A total of 90 charts prior to the study and 90 charts post-intervention will be included. The time period will be 12 weeks prior to the implementation of the Morris fall scale and the 12-week period during implementation. This will yield two fractions, one for the pre and one for the post-intervention. In the facility in which the project was implemented, there was no previous standardized fall assessment tool utilized by staff to assess the patient's risk of falling. The Morris Fall Scale was added into the admission and readmission packets at the facilities. These assessments were not yet added to the electronic health record. The Director of Nursing assured the researcher that the Morris Fall Scale would be added to the electronic health record of all patients if the project proved to be successful. The charge nurses were to complete paper copies of the Morris Fall Scale upon admission, discharge, fall, change in condition, and readmission. Initial Morris Fall Scales were completed by both this researcher and charge nurses to ensure that all adult patients had a baseline Morris Fall Scale in their charts. These screenings were kept with the paper chart at the nurses' station so that the charge nurses could access them for reference. Upon completion of the assessment tool, the patient score was calculated via addition and noted on the form. Patients scoring over 50 on the scale were assessed by the Director of Nursing, who decided which fall interventions were appropriate for the individual patient. These interventions included low beds, bed mats, bed alarms, and yellow anti-slip fall socks. During the retrospective review of the charts, it was found that between the dates of October 1st, 2024 through December 17th, 2024, that 15 patients experienced a fall after the initiation of the Morris Fall Scale. During the 12 weeks prior to the implementation of the Morris Fall Scale, which was July 8th, 2024 through September 30th, 2024, the number of falls at the facility was 35 falls. Approximately 27% of these falls included the same patient with multiple fall events. During the 12-week period when the Morris Fall Scale was introduced, no patient suffered from more than one fall occurrence. Via the use of the Morris Fall Scale, 58 adult IDD patients were deemed to be high fall risks, and fall interventions were enacted at the discretion of the Director of Nursing based upon the individual needs of the patient. For example, one 45-year-old male had a history of falls and fell from his bed onto the floor, sustaining abrasions on multiple extremities. He was transferred into a low bed with floor mats and a bed alarm to alert staff if he attempted to get out of bed on his own. He did not have a fall after the implementation of the fall interventions. During the scoring of the Morris Fall Scale, 58 patients scored over 50, making them a high fall risk. Of the remaining patients, 22 scored between 26 and 49, which is a medium risk, and 10 scored a 25, which is a low risk. Patients scoring greater than 50 were referred to the Director of Nursing, who implemented appropriate fall intervention strategies. Prior to the initiation of the Morris Fall Scale, the baseline fall rate per 1,000 patient days was 7.4. The total number of falls after implementation of the Morris Fall Scale over the 12-week period was 15. The total number of occupied bed days during this period was 7,560. Therefore, taking the number of falls divided by the number of occupied bed days, then multiplying by 1,000 reveals the new fall rate of the facility at 1.984 after the implementation of the Morris Fall Scale. The study's main limitation was the staff's lack of compliance initially and the shift in management during the implementation period. Nurses were resistant to completing the assessments, which led to some assessments being missed. After discussing this with nursing staff, the researcher spoke with the Director of Nursing regarding these concerns. The Director of Nursing was quick to rectify the problem via verbally counseling of the staff, which led to increased compliance. During the implementation phase, the Director of Nursing abruptly left her position. A new director was soon put into her position, and she continued to work with this researcher. She decided to implement the Morris Fall Scale on patients scoring moderately after she witnessed the effects of the patients scoring high. The changes in upper management did not affect this study. The role of the Director of Nursing was vital in the successful implementation of the Morris Fall Scale. Since an unknown number of patients were skipped during the readmission to the facility, the results of this study may be slightly skewed. However, 90 patient charts were reviewed, which was the initial goal of the study. And other staff members had differing views on what the definition of a fall truly was. To some members, placing a patient on the ground during a difficult transfer was not considered a fall, as it was intentional. To other staff members, this was counted as a fall. The term fall was initially defined for the staff, however, each member interpreted this differently. During this quality improvement project, 58 IDD patients at this facility were considered high fall risk during October 1st, 2024 through December 17th, 2024. Before the implementation of the Morris Fall Scale, there was no standardized fall assessment tool utilized at the facility. The Director of Nursing immediately implemented individual fall precautions for these 58 high-risk patients, contributing to the reduced fall rate. There is a possibility that these patients may have experienced a fall resulting in injury, hospitalization, or even death. Throughout the 12-week period prior to the implementation of the Morris Fall Scale, which was July 8th, 2024 to September 30th, 2024, 35 adult IDD patients experienced a fall. Some of these patients experienced multiple falls. After the implementation of the Morris Fall Scale, fall occurrences between the 12-week period between October 1st, 2024 through December 17th, 2024 dropped to 15. This significant reduction of falls not only saved the patients from physical and psychological suffering, but also created a sense of relief for their family members. It also reduced the cost of the facility in terms of treating a patient after a fall. Falls in the institutionalized patient population are a global healthcare problem. Falls in the IDD population are even more significant issue due to the vulnerability of these patients, implications, and their comorbidities. The fall rate in the adult population globally is 37.3 million, with falls in patients residing in facilities between 3 to 16 per 1,000 patient bed days. Every patient must be assessed for the risk of falling, but it is especially important on admission, readmission, and after a change in condition. Detecting patients who are at a high risk of falling allows for early interventions that will prevent injury and even death. These assessments must be ongoing for current and future patients to allow for all patients to benefit from the implementation of the Morris Fall Scale in this quality improvement project. Reducing patient fall rates at the facility is a vision of this project, as well as improving the overall quality of life in patients. Spreading awareness among staff members is key to compliance and adherence to the Morris Fall Scale protocol. A topic for future research would be to screen all patients at the facility regardless of their age. This would capture the 2 pediatric houses, or the 18 patients who were not captured in this study, but who could still benefit from fall prevention. Preventing falls in all ages promotes competent care and improving the quality of life for all involved. For 1 in 4 individuals over the age of 65 will have at least one fall each year. To mitigate fall rates, assessments must be completed in a time-sensitive manner, such as during admission and change in condition. Resources need to be made available to nursing staff regarding potential questions related to fall precautions and interventions. Increasing awareness in the staff and patient family members promotes compliance and enhances change. As with any policy change, the problem at hand must be showcased with solutions presented to mitigate the issue. Change is a process and is on a continuum. The policy of the facility will promote awareness, explore the screening tool in great detail, and will strive to promote compliance and teamwork. Funding for the facility stems from the foundation in which it was named after. In fact, via donations, this foundation pays for equipment, staff training, social events, therapy animals, and staff bonuses. While the Morris Fall Scale is free to use, the interventions required, such as low beds, bed alarms, and floor mats, will cost the facility. It has already been discussed with the Director of Nursing that fall prevention supplies and equipment will come from the foundation's money. There will also be positive outcomes for healthcare providers as hospitalization rates will decrease, saving resources and money. Falls in the IDD population have devastating results for patients who suffer from physical and emotional distress after the event. Thorough assessment by staff members using the Morris Fall Scale will lead to improved management of patients at high risk of falling. This quality improvement project has proved the benefit of utilizing the Morris Fall Scale in the IDD population. The results of this study captured patients who were at risk of falling and allowed for proper fall interventions to be implemented to avoid potentially devastating falls. The Morris Fall Scale has given staff members the power to assess and protect patients beyond their previous scope, as no standard fall assessment tool was used at the facility. This project recommends that all patients be screened using the Morris Fall Scale on admission, readmission, and with a change in condition. This will allow for staff members to implement individualized fall precautions based on the patient's needs to avoid potentially life-changing injuries and death. As the Director of Nursing continues this project at the facility, sustained quality of life will be maximized by reducing falls in a vulnerable population. The impact of this DNB project made at the facility was great. If I could go back and change anything, it would be to include the pediatric houses in the project. During my time at the facility, I heard of many falls in this population and believe the Morris Fall Scale would be an effective tool for them as well. The Director of Nursing plans to permanently implement the Morris Fall Scale for all patients at the facility, which will greatly benefit all patients going forward. Personally, this project has had a major impact on me. I feel a sense of accomplishment because I truly did help patients at this facility. The numbers and the data do not lie. There is no doubt that this was effective for patients. Going forward, this project provided me with the confidence needed to start my career as a nurse practitioner. In completing my education, I have learned patience. I have learned that I can make a difference in the lives of my patients. I plan to use this newfound confidence in my practice. Thank you.